Dr. Noman and Dr. Hamid has made my life very easier in explaining about the IVUS, the FFR, and about the OCT. So today is a very interesting topic about STEMI and multivessel disease, treatment of non-culprit vessels in stable patients. So 50% of patients diagnosed with ST segment elevation MI have multivessel disease on coronary angiogram. Recent guidelines indicate doing prime as a class 1 indication of doing a culprit vessel and class 2B for non-culprit vessels. Numerous trials have documented the usefulness and safety of a complete revascularization strategy. If you look at the complete trial, which indicate 26% reduction in the composite risk of death from heart disease and acute myocardial infarction at an average follow-up of 3 years. These were the patients who they were divided into two groups, one group in which they were staged PCI and the other only the culprit vessels was being dealt with. Now the decision, how to make a decision, which non-culprit lesion to treat with PCI rather than conservative treatment is controversial. How and when to perform a functional evaluation of an intermediate coronary stenosis that is 40 to 70%. Intermediate stenosis in non-culprit vessels represent 70% of the lesions in patients with STMI and multivessel coronary artery disease. And of course, if you do a coronary angiography is not able to evaluate reliably the functional capacity of these lesions, identifying plaque vulnerability, whether they are going to develop MI or not, or that could suggest an increased probability of ischemic recurrence. Whether intracoronary imaging can facilitate the identification of high-risk patients who could benefit from the revascularization of non-culprit lesions. We have to see the role of invasive functional assessment by the different trials, the FAME2, Dynamic 3, Primality, and Compare Acute. But there are certain pathophysiological caveats for the use of fractional flow reserve and instantaneous wave-free ratio in patients with STMI. FFR and IFR to guide revascularization in stable coronary artery disease. Reliability in STMI is controversial. PCI guided by FFR reduces rate of ischemic recurrence compared to PCI of culprit lesions alone. Multiple issues remains unresolved. Compare acute and median of 2 days after the prime PCI in dynamic primality, not clear when to integrate and intermediate non-culprit lesions. Prerequisite for FFR measurement is maximal hyperemia due to dilation of macrocirculation after intracoronary adenosine. With STMI have an incomplete response to adenosine due to increase in macrovascular resistance and reduction in coronary flow reserve, and can be fastly negative due to submaximal hyperemia. Adenosine is unable to eliminate alpha-adrenergic or endothelium-mediated coronary vasoconstriction or other powerful vasoconstrictors such as angiotensin, thromboxane A2, and serotonin. Non-culprit lesions can be associated with plaque rupture and distal embolization, which hinders vasodilator response. Endothelial dysfunction and increase in left ventricular endosystolic pressure can cause alteration in myocardial perfusion. IFR calculated in period of diastole are absent in a phase of cardiac cycle in which macrovascular resistances are lower and more stable. IFR performed in the absence of hyperemic stimulation, thus avoiding any stimulations regarding incomplete response to adenosine. Now, if we compare between fractional flow reserve and instantaneous wave-free ratio in patients with acute coronary syndrome, these results suggest a transient change in macrocirculation responsible for a flawed functional evaluation of non-culprit plaques, more significant in patients with large heart attacks. Non-hyperemic indices such as IFR can overestimate the severity of non-culprit lesions. In acute phase of STMI and FFR can underestimate it. So the role of intracoronary imaging is important to understand. If we just compare the IVUS, the OCT, NIRS, and the OCT, which indicates the clinical importance of local inflammation, the accumulation of macrophages and lipid accumulation. So this is the OCT image of characteristics of vulnerable plaques, which indicates the fibrolipid plaque with macrophage infiltration with white arrows, large lipid load with an asterisk mark, and thin cap fibroadenoma with dotted images. So latest guidelines do not give a univocal recommendation as to the imaging technique of choice, and that is SPECT, CMR, or PET to detect residual ischemia and myocardial viability in patients with STEMI, which also depends on local availability and experience. If we compare all these three, the stress SPECT, CMR, or PET, stress echocardiography is difficult to apply due to basic kinetic anomalies and the risk of ischemic and arrhythmic complications when performed in an acute phase of STMI. CFVR coronary flow reserve assessment with Doppler transthoracic echocardiography in patients with intermediate stenosis can be considered within 7 days of primary PCI when technically feasible. CMR, late gluten enhancement, offer high diagnostic accuracy in evaluating the transmural extent of scarred myocardial tissue. However, was not superior to other techniques in identifying vital myocardium and predicting contractile recovery. So PET is also an alternative to non-invasive technique for evaluating perfusion and residual myocardial ischemia, but is not available as limited availability due to high cost. CT angiography could also be done in non-culprit lesions. Diagnostic accuracy of FFR CAT can also be used to detecting ischemia with STMI. The European guidelines indicates a class 1 indication of doing an FFR, IFR to identify hemodynamically significant stenosis is indicated for evaluating such non-culprit lesions. So we go with the algorithm, that is the ST segment elevation MI with multivessel disease in 2 groups, intermediate non-culprit stenosis that is 40 to 70%, or a significant non-culprit stenosis that is greater than 70%. If it is greater than 70%, is easy. You go with the complete revascularization during original hospitalization. And if it is intermediate non-culprit lesions, that is 40 to 70%, PCI non-culprit lesions can be done either by doing an FFR, IFR, and guided PCI within 5 to 7 days after massive MI. Or consider intracoronary imaging during initial PCI for detection of vulnerable plaques. If the vulnerable plaques is detected, high-dose statins, long-term dual antiplatelet therapy, cardiovascular risk factors control, and anti-inflammatory drugs, carnacunomab if CRP greater than 2. So in conclusion, decision to treat with PCI or to manage non-culprit plaques in patients with STMI with optimal medical therapy remains controversial. Assessment of functional critical lesions with FFR or IFR must be performed in the subacute phase of ACS, preferably after 5 to 6 days, especially after large myocardial infarction. Otherwise, it will be unreliable. The role of FFR, IFR, improving the prognosis of patients with STMI is limited since cardiovascular events may derive from functionally insignificant stenosis but with characteristics in vulnerability. Thank you.